course, you go through, could I have been healthier or was it my fault? You go through these things and it is a life-changing experience. Hi, I'm Daniel Herson and I have mantle cell lymphoma.
Mantle cell lymphoma is a rare type of B-cell non-Hodgkin lymphoma. What makes it unique is how it begins in an area of the lymph node called the mantle zone, and that in fact is where it gets its name from. This condition was first described in 1982 by a pathologist named Dennis Weissenberger. He noticed a specific pattern in aggressive lymphomas where the abnormal B cells would grow and expand the mantle zone of the lymph node. Back then, it is called mantle cell lymphoma. Later, with the advances in the cytogenetics and molecular biology in the late 1980s and the early 1990s, Dr. Mike Williams and his colleagues discovered the key genetic hallmark for mantle cell lymphoma, which is the translocation between chromosome 11 and 14. This genetic event moves the cyclin D1 gene, which is located in chromosome 11, next to the immunoglobulin heavy chain gene located in chromosome 14. And this leads to the overproduction of cyclin D1. And the overproduction of cyclin D1 drives the uncontrolled growth of B cell in mantle cell lymphoma. In Asia, mantle cell lymphoma is relatively rare. It accounts for 2 to 6% of all lymphomas, and studies have shown that it is less common here than in Caucasian populations. There are two main subtypes of mantle cell lymphoma. The understanding between them makes it important both for diagnosis as well as deciding on the correct treatment approach. The first is called classical or nodal mantle cell lymphoma. This is the most common type, making up about 80 to 90% of all MCL cases. It tends to behave more aggressively and it often affects lymph nodes and spleen and also spread to other parts of the body like the gastrointestinal tract. The second subtype is called leukemic mantle cell lymphoma, also known as non-nodal MCL. This behaves more indolently, which means it grows and spreads more slowly. It often first detected through a high lymphocyte count through routine blood tests.
I think I started notice something in December 2023 around Christmas time, like a small bulge on my groin area. But at that point, I didn't realize there was something serious. I actually thought it was something to do with exercising or something similar. And then for a few months, it still didn't go away, and I realized I was a bit tired, more tired than usual. And so eventually around February, March time, I went to the doctor, just a GP, and he then suggested I would do some scans. And through those scans, eventually it was discovered that it was mantle cell lymphoma, and I was diagnosed, I think, end of March 2024.
Typically, patients with mantle cell lymphoma present with lymph node enlargement, which can occur in the neck, armpit, or groin area. They may also experience the so-called B symptoms, such as unexplained fevers, weight loss, and night sweats. In some cases, patients with leukemic variants of MCL are discovered incidentally, with routine blood tests showing an elevated lymphocyte count.
So I was initially diagnosed in the Philippines, where I live and work, by one of the specialists there. And once I found out, we decided to immediately get a second opinion in Singapore and also explore treatment options. Almost a few days after the diagnosis, we met with 2-3 different hematologists, and all very good, but we felt we had a really good connection with Dr. Lim and explained the situation and different treatment options. And from there on, we decided to go with Dr. Lim and focus on starting the treatment as soon as possible.
When a patient comes in with a persistently enlarged lymph node, the first and most important step is to do a biopsy. That's the only way we can confirm what type of lymphoma we are dealing with. If the results confirm mantle cell lymphoma through histopathological examination, we move on to staging, which means finding out how far the lymphoma has spread in the body. At the same time, we need to perform risk stratification to assess how aggressive the disease might be. The process usually includes PET scan, blood tests, and a bone marrow biopsy to complete the picture. Early diagnosis helps tailor the treatment strategy. It helps us to decide if a patient needs immediate or aggressive therapy for classical MCL or watchful waiting for indolent forms. This can have a meaningful impact on both survival and quality of life.
Getting the diagnosis of MCL, I mean, it's a bit confusing first because I never heard of MCL, and something like cancer feels very, I had cancer in my family, but until it's so close to you, it's like, happened to yourself, it's very hard to really understand what goes on. So in the beginning, of course, as you do, you go to Google and you put it in, and that's very scary and not recommended. Then you read all the horror stories, and you're going through this kind of phase of confusion, learning, fear, but it's so much happening at one time. So it's hard actually to comprehend what's going on. And then also at the same time, you're trying to find the doctors, the different treatment options. So the first week, I think I was so busy just understanding what's happening. And maybe the second or third week, you start thinking that this is very serious. But there are treatment options, and you're going through this kind of roller coaster of emotions around fear, we're happy to life, treatment, but also just getting into action. When I heard that I had mantle cell lymphoma, it was a bit confusing because I don't know what mantle cell lymphoma is. I didn't even know what lymphoma was. And then you realize that in the world of cancer, and there's so many cancers, there is also the world of lymphoma. And within that, there is mantle cell lymphoma. And within mantle cell lymphoma, there are different variations of it from what I understand. So the doctor's trying to explain a lot of these things to me, but it was overwhelming. And of course, you try to learn yourself. What I know about cancer, and even if I had it in my immediate family, it's so different when you get into the specifics of it. So it's really, really important to be able to get that kind of really detailed, but also just being able to ask questions. Some questions maybe seem trivial, some less trivial. Will I lose my hair? What will happen to me? Well, all these things that you want to ask, but you never really knew about until you have it yourself.
When it comes to treating mantle cell lymphoma, we really tailor the treatment to the individual based on their age, overall health, existing conditions, and what they personally prefer. For younger and fitter patients, the traditional approach has been intensive chemotherapy, followed by an autologous stem cell transplant, and then maintenance therapy. That has been the mainstay for years. However, the Triangle trial suggests for fit patients, adding a glutathione kinase inhibitor or BTKI into first-line treatment and maintenance might be just as effective even without the need for stem cell transplant. That could change the standard of care for fitter patients moving forward. For older or less fit patients, we use a gentler approach. We go with less intensive chemoimmunotherapy followed by maintenance therapy. The goal is still to control the disease, but in a way that supports good quality of life.
Once we had the diagnosis and more details, we did several tests, of course, like the biopsy, the bone marrow biopsy, and the scans. We were narrowing down the different treatment options. And we decided initially to go for something I think is called the Nordic protocol, which is the standard way of treating mantle cell lymphoma. It's a quite aggressive treatment. And I should say, when I found out I had mantle cell lymphoma, I had stage 4. So it had spread all over the body. When you hear stage 4, you immediately get scared, because what I do know about cancer is stage 4 is serious. What I learned as well is that most blood cancers, like mantle cell lymphoma, leukemia, usually when it's detected, usually stage 3 and 4. And the way it works is that, stage 4 means different for different types of cancer, I realized. And explore the different treatment options together with the doctor. Look at the pros and cons. So we decided to go with the Nordic protocol, which is a cocktail of chemotherapy and immunotherapy, and read up about it. And there was still some of these options, or newer treatment options, are still relatively new. Maybe they've been in the market 5 years, maybe less, particularly for mantle cell lymphoma. So we quickly switched, actually, in the first treatment phase to this newer sort of treatment plan. We did that in consultation with the doctor, but also he also consulted one of the authors, one of the main authors of the article itself, who happened to be in Singapore at the time. And that author recommended we should explore this way instead of the Nordic protocol. Talking to the doctor about the different options. I feel it's good to be proactive, both so that you know what is happening, but also so you do explore these options. I recognize that for different people it's maybe different, but at least for me it was important to know what options I had and understand the pros and cons of the different solutions and treatment plans. So the treatment itself, again, you have these ideas of what chemo and immunotherapy looks like and feels like. And actually, I imagine horror stories around it, right? That I would lie down and throw up and everything. But it didn't happen to me. Not to say that was pleasant, but it was definitely not as bad as I expected. So one thing I realized, for example, is that, you get very, very hungry immediately after each treatment cycle. I think it's a link to the steroids you take. So you eat a lot and you crave carbs, and I ate like enormous amount of food without gaining any weight, which is great. Pizzas at night, ice cream and so on. You get this like cravings. But it also helped me. I realized that before treatment, I had none of those problems. Of course, there were days when you feel down and you feel empty and tired. It's good then just to do nothing and just rest. But I tried to also exercise a little bit, to walk, go to the gym a little bit between cycles, and that worked quite well. Didn't try to push it. Work-wise, I actually, my work was very generous. It's possible to take the whole time off, but after actually a few days, I got bored. So I still worked, I would say maybe a third or half the time during my treatment. But that was really for my own personal need, just to stay busy and distract myself. This is really a time for reflection, right? When you go through treatment, it's really emotional. It's physical, but I think for me the emotional part was almost bigger than the physical part. It becomes a routine. I had 6 cycles of treatment. Each cycle maybe had, and this again, I had no idea what a cycle meant, but effectively you have 1 or 2 days of infusion of different drugs, chemo, drugs, immunotherapy, all sort of through IV or a line that goes into your body. I read books. It was a good time. It's a time for self-reflection, and it's a time to look after yourself, I think, right? And everyone around you will look after you, but I think the most important to me was for me to look after myself and take that time, which usually and normally is hard to do, right? I have 3 children, so it's hard to get that space.
Once the initial treatment is complete, whether it was chemotherapy or a stem cell transplant, we typically do a PET scan to show how well the lymphoma has responded. If the patient achieves a complete response, we move on to post-remission maintenance therapy, which typically lasts about 2 to 3 years. Maintenance therapy usually involves taking an oral BTK inhibitor every day, along with an anti-CD20 monoclonal antibody injections every 2 months. The goal is to reduce the risk of relapse and to keep the disease under control for as long as possible. We also follow patients closely in the clinic. In the first few years, we see them every 2 to 3 months for a history, physical examination, and blood tests. Of course, the exact schedule can vary depending on patients' condition and preferences, as well as the treating physician's approach. In terms of imaging, we generally perform imaging like PET scan or CT scan only when it's clinically indicated. For example, if the patient develops new or worsening symptoms, or if there's other evidence suggesting disease progression. Traditionally, BTK inhibitors such as ibrutinib, acalabrutinib, or zanubrutinib have been the go-to options at first relapse. However, with emerging data like the Triangle trial, BTKI are now increasingly being used upfront as part of frontline treatment and maintenance. This means we have to think very carefully about what to use next for this group of patients when they relapse. At the moment, there's no single universal standard, but key options include CD19-directed CAR T-cell therapy, non-covalent BTKIs such as pirtobrutinib, and other targeted or chemo-based regimens depending on the individual situation.
So it was a tough time, but you do have help, and I think it's important to seek out that help. So of course for me, family was really important. My kids, my wife, my sister and others were there. I involved them throughout the process. My children shaved my head. I mean, when I started losing my hair in the second cycle, so my children, I allowed them to ask whatever questions they want to ask, and also brought them to meet a doctor so they could ask the doctor questions. But I think that was important for them to feel part of the journey. And that helped me as well to feel that, I can explain to them that, I'm not feeling well, but fingers crossed everything will be well, I'll be fine. I got through a phase where I started reaching out to friends I haven't talked to maybe for a while. I live far away from my home country, which is Sweden. So I started reaching out to friends I haven't maybe talked to for a few years. I got through a phase where I became very sentimental and almost nostalgic about my past and who I am. So to reaching out to those kind of friends who knew me since I was young was really important too. Everyone is really supportive, but I think it's important to be proactively reach out to some people. And I also think after a month or two, I also reached out to professional help, a therapist, a counselor or therapist, which was really important to guide through because you're going through a lot emotionally.
In my experience, patients with mantle cell lymphoma cope in very individual ways. On the emotional side, many patients initially feel quite overwhelmed by the diagnosis, especially when they hear terms like aggressive lymphoma or stem cell transplant. Anxiety and uncertainty about the future are very common. Over time, most adapt better when they feel well-informed, supported by their care team, and connected family and support groups. On the physical side, treatment can be demanding. Chemotherapy and stem cell transplant often bring side effects like fatigue, nausea, or infections, and many patients need help managing day-to-day activities during intensive phases of treatment. That said, with modern supportive care, many are able to maintain good quality of life in between treatment cycles. What really makes a difference is close communication and support. We take time to explain the plan, set expectations, and involve family and caregivers. Referrals to counseling services, social workers, or patient support organizations can be invaluable. So overall, while the journey is challenging, most patients cope far better when they feel empowered with information, have a strong support system, and know that their care team is walking the journey with them.
And it's still teaching me a lot, by the way. I think another thing that I realized, you have the treatment, and the treatment took a couple of months, 3-4 months, it's quite intense. But there is a period after the treatment, which is as intense in one way as the treatment itself. Because that's when all the reflections comes, you start realizing what you're going through. And then with MCL, it's a risk that you live with for the rest of your life. That's one thing people didn't prepare me, is that after the treatment, it's still a lot to do. It's still a lot of physical and mental recovery. And so I wouldn't underestimate that part of it, that journey. It changed a lot. There's a saying that someone told me during this beginning of treatment, which I think was quite apt. But every person have 2 lives. You only get a second one when you realize you only have one.